Thank you. We're beginning. So as I was saying, again, if you just look on, I just added these. I created Unit 2, which is week 2. And I've added these two PowerPoints, which is the start of the second unit, joints, uh, which are a relatively small part of it. And I think this is the Welsh Hall textbook chapter. I'll have to double check. I go back to last year. Last year's fall of 24 to be able to do that. So I did. Cough drop in mouth. So I'm having trouble enunciating. My voice could be doing better. And here we go. Back to the beginning. Okay. It's called, again, always the frame this time of year when you start looking at bones for fractures, for joints and muscles. Look at all the stuff you're seeing. The dislocations, the hamstring pulls, Najee Harris tearing his Achilles when he hardly, out of nowhere. I didn't see James Connors the play, but they had to know right away. I don't know. I mean, they just within hours of that injury and him being off the field. Terrible. Okay. When we think about joints, the first mistake students make is they equate that with movement. Joints don't necessarily move. They are indeed classified by either the absence or presence of motion, as well as their structural material. As you will see, there are 3 different classifications, 3 anatomical, 3 physiological. We typically use the physiological ones in order to, to study this material. So and we'll go from there, right? So structural, based on what material binds it. Fibers. You would think that would have the most movement. It doesn't. The skull sutures. Those fibers, basically, as the baby begins to mature, what happens a lot with fibers, it does in scar tissue, it begins to shrink, pull tighter and tighter and tighter. So the union between those bones is made of very, very tough, insoluble fibers that are holding those bones together. So a fibrous union has the least, and it does not have a marrow cavity. Don't make the assumption that a synovial cavity. So the idea of a joint cavity, if you have a joint cavity with something that you'll learn about shortly called synovium, understand that's where movement comes from. Fibrous, the least amount of motion. Cartilaginous has a subtle amount of give. We talked about that in the lab last time when you looked at the sternum and the costal cartilages. While they're cartilaginous, you have a greater degree of chest expansion as they begin to ossify with old age, less so. And that'll clue you in to where the cartilaginous has a subtle or slight amount of motion. You'll see the classifications called amphiarthrodial in a second. Synovial, freely moving. Probably less of those joints than any other, although they are the most important with regard to arthritic changes. Really, we don't see arthritis in fibrous and cartilaginous joints. We see damage, but not arthritis per se. Arthritis is an inflammatory process, and you see that almost exclusively in synovial joints. They're named for the lining, which is extraordinarily interesting, very, very well studied, and one of which, just like bones, I am very familiar with. Because what I was, for all intents and purposes, was a bone and joint surgeon when I did surgery. I did skin stuff, I did some nerve stuff, but the vast majority were bones and joints. This is the functional movement. It's a little easier. Syn for without arthroses, amphi for some, slightly movable, synarthroses immovable, diarthroses, I don't know where they get that name, so I use the term synovial for freely moving joints. So they're going to use the structural classifications, whatever floats their proverbial boat, as my daughter would say. Here we go. Pardon me. Dense, fibrous connective tissue. Not just collagen fibers, but really the fibers are a sort of a combination of fibers that are even structurally have less give that are there. There is no joint cavity. Most are immovable. So I'm just reading it to you, and it has to do with the length of the fibers. The shorter they are, or as they shorten, it becomes less mobile. The longer they are, that's those fontanelles in the skull, they have a certain amount of give that are there. So you're going to see the ones you certainly are the most familiar with are called sutures. And so, and again, it's because they have that appearance of the old style suturing when people didn't understand the cosmetics of sewing skin to skin. Yes, short connective tissue fibers that allow for some expansion. Okay. Over time, these really just make the transition to bone. Okay. I don't know that this is necessarily true. When they talk about closed immovable sutures, when I think of a synostosis, and it's not something you have to know, sometimes people have bony block where they shouldn't have two bones connected by a bony bar. They do. There's classically one in the foot called the tarsal coalition, which is usually involving the calcaneus and the talus bones that you're going to look at today when we start talking about the extremity, the rest of the extremity bones. So, I mean, again, whoever writes these PowerPoints, I have to view everything from a clinical perspective, not from, an anatomical, academic perspective, if indeed that's who's putting this together. Here's the fibrous connective tissue. Okay, they interlock in a very distinctive pattern, reminiscent of a suture line. Syndesmoses, ligaments, bands of fibrous tissue. Ligaments, as you remember from laboratory, are a mixture of collagen fibers and elastic fibers. Ligaments have inherently a certain degree of stretchiness. So the shorter fibers, less movement. You'll see very shortly the inferior tibiofibular joint. Longer fibers, more movement. You're going to see this, and it ties into the extremity bones. The tibia and fibula, your two leg bones, are connected by something called the interosseous membrane. It is relatively tight and immobile, whereas the radius and ulna are designed, okay, to be able to do this. Okay, if they couldn't do this and move as freely if they didn't have a structure to them that permitted it. So even though they're both made of the same thing, the point I'm trying to get across is the arrangement of the fibers. The very important inferior tibiofibular joint. Voila. So now you get to see the distinction between the ankle sprain and the Faraday's high ankle sprain. So, I mean, you hear a lot of these things. This is a very, very tight, this is their poster child for the syndesmosis. This is a ligament, called the aptly named the inferior tibiofibular ligament. Fibula, the smaller. It's held extraordinarily tightly there. Here's the ankle joint. Talus is the bone that's over there where my finger is. As you move down, a typical ankle sprain is here. Typically goes from the tip of the fibula, notice coming in okay, the lateral malleolus, down to the calcaneus or to the talus. I'll show you where those ligaments are. Not today, some other time we'll go into the mechanics of the joints. That's a typical ankle sprain. The ankle joint here is below it. The high ankle sprain involves bone here, the tail is coming up and pushing these bones apart up in that ligament. In the old days, we projected the dye before we had the luxury of MRI. See the dye going down. That really points to the high ankle sprain. The healing time is dramatic. High ankle sprains can require surgery. When we had bad ones, we used what's called a transfixation screw. You had to put a screw through here, and here. You didn't want to limit the motion entirely, so you didn't put it all the way through and engage what we call 3/4 inch. Now, you see the same thing with the Tommy John surgery. They're using, it's almost like a flexible, thick band that's trying to take the place of those ligaments and holds it together. Okay, so there's a more dynamic, it's by nature more dynamic. Yeah, it requires a fair amount of time. By and large, if it's something they can come back with, an athlete can come back with, let's say this season, it has to be something that probably be 3 to 6 weeks average, 6 to 8 weeks if it's worse. They can really be pretty nasty. Who's got Alex Highsmith's got, and that has really limited his, and he's a big pass rusher. So it just gives you an idea. This is where you begin to see that structural stability. This holds basically the foot to the leg. And so what happens when it's a severe enough amount of trauma, you're going to see the dome of the talus goes in and basically just pops those bad boys apart. Teeth. Now, gomphosis, peg and hole. Okay? The only thing that holds your teeth, technically, it's a joint, believe it or not. They're not supposed to move. I realize when you have new teeth coming in, they move. And as you're older, a lot of times it's just a decaying process affects that. But if you ever had a tooth extracted, okay, that's the hard part to get out. Getting out that period, that's the one where they got to dig in there. And I mean, if you're an SU, it's like, oh my God, what are you doing? When this wears off, it's going to be a horror show. My wife had one of those because they were in that very socket. She get an implant done, and they were putting like the receptacle part. So it's like the implant has like a screw on it. So you got to put what the screw is going to seat into. And she said and this was last Tuesday, she was an hour in the chair. She was not a happy camper when she got there. I told you, she thinks that the doctor's a good-looking young guy. Cougar. It's okay. I can live with it. She goes, I talk a good game, but that's it. Here we are. This is that ligament there at the very bottom. So it's called a gomphosis. The word gum would help me remember that. Okay. That's how I remember it. I try to tell you how I remember things. Even I, who am blessed with a very good memory, have to utilize tools for memory as well. Now, the cartilaginous show you have the suture joints, that syndesmosis is fibrous, and certainly the ligament is fibrous. In cartilage, you only have two. One, these are unions. Synchondroses are made of cartilage. Symphysis is fibrocartilage. They do not have a joint cavity. These have a small but limited amount of motion. So a bar or plate of hyaline cartilage unites. Okay. By definition, the epiphyseal plate would be considered that because there is a small amount of motion that's there. And again, I don't know if that's the world's best example. I mean, maybe the better one, the cartilage of the first rib with the manubrium of the sternum. So here's the manubrium, you just feel the notch. Right over there, that first rib is just below there. I mean, that's the one that has probably the most motion of all the ribs. I would accept that. Well, I don't like that first one so much. To me, epiphyseal plates really don't move in kids that much. If they've moved, it's because they've really been traumatized. To me, that was usually there's enough pain for that to really be consistent with a diagnosis of one of those type 1 fractures. But when they close, okay, now they're calling it synostosis. It's a transition from cartilage to bone. I mean, I won't ask you about that because it's dumb, I think. And the manubrium sternum, that's what they're pointing at. Here's the manubrium, here's that first rib. That's the area where you feel your upper extremity moving. That's that sternoclavicular joint. So it's immediately below that. So they're giving you those. I don't buy that. Symphysis is a big name. Symphysis are those intervertebral discs we looked at last time in lab. They are fibrocartilaginous, okay? So, I mean, hyaline cartilage is also present as an articular cartilage on bony surfaces. I'll buy that. Symphysis, intervertebral joints, and in between the two pubic bones that we're going to look at today, there's a fibrocartilaginous pad, okay? So symphysis in the plural of symphyses, you just substitute at the end, obviously, an E for the I. All of those are consistent with this. And they are, and really there's a fair amount of motion that you get. It all contributes along with these, the joints that are pointing up and down that we talked about last time in lab, the superior and inferior, those are what we call sliding or gliding joints. A little bit of motion. It's sort of complemented a little bit by the motion. It's not that you're going to be bend and be able to contort things. When you see somebody who's a contortionist, Typically, that has to do with a genetic disorder that allows them to be extraordinarily hyper flexible. I mean, it's an end product of something. I actually saw one of those in something called Ehlers-Danlos. You don't have to write it down. Danlos, Danlos syndrome. That's two proper names by people. I saw in the VA hospital back 50 years ago. This guy, a vet, his skin could literally come up. The old India rubber man. Skin could actually, you'd have to cut the skin. You couldn't just stick a needle through. The needle would bend. And that's somebody who generally has this remarkable, they're way past double jointedness. It's extraordinarily flexible. And again, most of those have to do with hereditary aspects of things, or maybe typically the old days they call them collagen disorders, because there's something wrong with the connective tissue. So I say it to all the classes. If you see something once in a career, those are the type of things you see once, maybe twice. People talk about, the flesh-eating bacteria. There's less than 200 cases a year probably in this country. It's just not that common. The fact that I saw two in my career underscores that. So, synovial joints, diarthroses, freely moving. As you will come to see, the whole idea of what we're talking about here is the structure will tell you how the joint moves, whether it moves a lot, whether it moves a little, but in this case, inherently it is mobile, and the ends of the bones don't touch each other. There's a finite space we call a joint cavity. That cavity is filled with for all the world, a lubricating fluid called synovial fluid. It is secreted by the cells that it is named for, called synovium. It's one of these double layered things you're going to see a lot of. We looked at it a little bit in the early lab. In that case, we talked about things had an outer, it's like the pleura or the pericardium. The layer that's against the chest wall or against the organ, and then on top of it, it has a very thin, delicate layer that technically is the pleura or the pericardia or the peritoneum. So it's very, very similar with regard to this, and I'll try to represent it on the board with what we call Stein's bad artwork. Just saying. Includes almost all limb joints. There's very limited exceptions. I don't necessarily buy all these 6 general features, at least not in their degree of importance. I think they're full of baloney. Many of them have what are called bursae or tendon sheaths. These are additional sacs of synovial fluid that either surround things or form between them. Some of them we are born with, some of them we acquire because of the activities we do. So they describe it as like being a ball bearing. I mean, I don't know enough about mechanics to tell you that type of stuff. My kid does. That's his ball box. There is certainly things that impact stability, and this is where I disagree with some of the things that they say. They allow different types of movements. There are 6 that we will classify. So effectively, draw this. You draw it in a couple directions. I use very generic within my artistic lack thereof capability. We usually represent cartilage and glue. Remember, this is hyaline cartilage. That's the remnant, because these are long bones. When as it was replaced by bone, what was left at the end of the bone was cartilage, hyaline cartilage. Okay, it's a little broader than you think, and it forms against. It's a little thinner than you think. Okay, so it's not. I don't think it's quite as thick as they would represent. Surrounding it, top to bottom. Maybe if I turned around and drew it this way, 3-dimensional aspect. So I'm looking at an overview of it. Same deal. surrounding it entirely is a thing called the capsule. When you look at the capsule, it has the fibers are very well organized. That like that. Better to demonstrate it here. This is relatively thick. The internal lining, which has some connective tissue underneath it, is simple squamous cells. And those cells, I'll just draw it up here, but just do it from just looking at it and focusing. Quite thick and fibrous, that's where it gets its strength, the capsule. Dense irregular, irregular. This is simple squamous on the interior, and what it secretes are droplets of this fluid. So this is referred to as synovium. Hence the name synovial joint and synovial fluid, or joint fluid. All synonymous terms. So the hyaline cartilage, the end of the bones, I don't know that it prevents crushing the end of the bone. Where do they get that stuff? Having a moment. Okay. The synovial cavity is this, they say fluid filled potential space. It's a space. So it's, when I say finite, you can measure it. It's not very big. And the fluid is very, very distinctive. We look at the viscosity. Is it like motor oil? Probably a little thinner. It's certainly not, I mean, it's the type of stuff that one of the tests we do in surgery is you get a little droplet, you put it on your finger and you try to pull it apart. You want to check the stringiness, and you can check, you can drop it in like acetic acid, like vinegar, and test the stringiness. Those are all little tests to determine that you get an idea of almost what's going on, what kind of arthritis from looking at that. Synovial analysis is extraordinarily important. We aspirate joint fluid. Sometimes you aspirate fluid diagnostically. You want to see if it's an infection. You can, if it's a bleed, you're going to know right away. Because if you've aspirated a knee and you've torn a ligament in a knee, it's coming out blood. It'll be completely bloody looking. That means there's a lot. Again, a little blood goes a long way. That fluid, if you've torn a ligament, there's going to be blood. I can remember the orthopedic surgeon for my middle one. I think, did I tell you, he's a BMX, he used to do BMX bike riding, backflips, dirt jumper. It's one in every family. He's got a motorcycle, I know. It's like I'm worried every minute. And when he was 16 or 16 and a half, he flipped one of those doing a backflip and put his leg down, his left leg down for, to basically brace himself. And sure enough, there goes the ACL. And it just blew up like a balloon. The next day we saw the orthopedic surgeon, who we know because her son and my older son were buddies. Okay. And she goes, and she stuck that needle in and she pulled out, took a 50 cc syringe, all blood fluid. She goes, oh, his ligament's done. So, I mean, early days, he had to have that grafting procedure. This is 2000, 2001, 24 years ago. And that knee still acts up pretty good. I mean, the surgeries have improved over time. Nevertheless, that fluid is important. We will very often remove it to analyze it. You can tell different kinds of arthritis, infection. I'll go into these with you. The various kinds of arthritic conditions. Very, very interesting stuff that is there. The capsule itself, the external fibrous layer, dense irregular. Underneath the inner layer, anytime you're underlying any epithelial tissue, you always have loose irregular connective tissue, and then that lining additional. It's not the connective tissue, it's the synovial lining that makes the fluid. It's not unlike the same thing if we look at when you look at those eccrine and merocrine glands, them doing that. Synovial fluid, viscous, slippery. It has plasma. What gives it hyaluronic acid is something that we see a lot of in joints. You go into any pharmacy, go to Costco, go to Sam's, where all the meds are and that type of stuff. You see these giant bottles of things that have MSM, glucosamine, hyaluronic acid. Those are all, people take those supplements. It's a protein. And it's a combination of proteins and what we call proteoaminoglycans, and nitrogenated carbohydrates and proteins, the structural materials that are there. And if you take more of that that builds joints and cartilage and fluid, the theory is that it would improve. And a lot of people, myself, have been aided by taking those things. There's a text from the boss. Hold on. Just checking. So all of that, very important part of it, that's there. There are white blood cells to remove microbes and debris as well. Yeah, I'll buy that it lubricates and nourishes it. Ligaments are interesting. This is where we're going to get to the knee. Ligaments basically provide stability. They have a certain amount of give because the ligament, like a tendon, which is more of a rope, it's a rope that has some elasticity. So ligaments go, this is where the anatomy comes in. I'll show you some of them today. They go from something, the articular surface is often referred to as the condyle. So when we talk about epi, outside of the condyle, there are little bumps that are here and here. Ligaments tend to go this way. So you have one on each side. Let's go here and here, here and here. So that way. Those are called collateral ligaments. Okay. New defensive tackle, rookie first round draft pick. Just looking for precision. He's had a sack yesterday. He hit the preseason NFC also. Medial collateral. Lateral means obviously lateral to medial, but it's collateral implies which one is. So when you get to the knee, depending on what you're looking at, we'll probably take a look at that a little bit today. You have collateral ligaments. That's part of it. So ligaments can be either part of the capsule, as you can see here. They can be inside the capsule, we call it intercapsular, and often have covered by their own synovial membranes. A classic example of those, the anterior, posterior cruciate ligaments. So this is the chapter where we explore those. Frequently damaged ligaments that are a really significant problem. Extracapsular means they're outside the capsule. So unlike the way I draw it here, they would be exterior to the capsule. And then many of them are just capsular ligaments. They're really just a thickened part of the capsule. Interestingly, the knee has all three. Why the knee is the most complex joint in the body? Because it's got all, among other things, involving not two bones, but three. Involving not one joint, but more than one joint, effectively. Okay, and it has intercapsular ligaments, extracapsular ligaments, and capsular ligaments. And then it's got cartilage discs in there anyway to increase the ability, the range of motion. I mean, it's a mind. So it gives you an idea. So there's some of the joints are really very interesting in that regard. And then obviously nervous and joint position and blood supply, gotta have all that stuff. There's their diagram, and it gives you an idea. I tried to draw the capsule with that kind of a, oh my God. It's okay. Remember that crown? Now she really doesn't like the dentist because she just had to pay a lot of money. Your timing is always perfect, my dear. Nevertheless, here, better illustration I did. But I draw those because there's movement in multiple directions. The way the fibers are arranged, when I would open up a joint, you would see those fibers. We would make sure to maintain that when you cut and size the joint to remodel it, which I did a lot, or to put an implant in, which I did very infrequently, or to break and reset the bone close to the joint level, which I did with some degree of frequency. Okay, all of the above, that capsule you would preserve and you sew it back together. But the fibers, the pattern would have to line up exactly. It would be like buttoning a shirt and getting them off, having this button up here. You know what I mean? In surgery, we call that when you don't line it up properly at the end, you have a little piece. We call it a dog ear. So you have to do that. Maybe I told you I knew a lot of surgeons who got a sterile stylus and then they basically marked where the incision was going to be and marked across those things and they line it back up. And sterile stylus is just sterile methylene blue. It's like a sterile pen that's methylene blue. It's not going to harm anything on the inside. And so it's a lot wider than you think. And that's the good news. The bad news, when someone has arthritis, little pieces get stuck in here. So sometimes when someone gets a joint that freezes, it's because a little fragment has broken off and jammed this apparatus. It goes back to those accordion pleats. So the joint has accordion pleats, things that I have talked about before. And those accordion pleats generally allow, look at it. Here's my elbow stretching here, contracting here. So if I do this, it stretches here. It's got to be able to fold in. You see this again. You see it in the knee. My ex had one of these. Bless you. She was doing ballet, and she was in when we were living up in the Oil City area. They had a dance recital thing, and my kids were in it, and they needed somebody. They were doing inevitably the Nutcracker for Christmas, and she's doing all that stuff, and all of a sudden it's like, oh my God, my knee is free. So we had to go up and see an orthopedic surgeon up in Hammond, which is really the closest big hospital at that time before they built UPMC Northwest in that neck of the woods in the Oil City Franklin service area. And it's called a plica, Plica. Application is the name for sure. It's like, imagine it should be folding in like an accordion, but it folds out. And it's almost, again, it almost periodically would jam. She was fortunate that exercises would strengthen it and it didn't have that tendency anymore. So you didn't have to do any surgery. Otherwise, you would have to do some type of knee procedure arthroscopically to have that done. So that's very interesting because this guy did all sports medicine. He's very good. So other things that you see in there, fatty pads. Okay. And this is what the name would suggest for cushioning. Okay, the cushioning, fibrous layers of capsule and synovial membrane or bone. So we see this in a variety of joints that are there. Okay, it's sort of like Mother Nature making sure that pressure is resolved within these areas. So they're not all of them that are there. And now articular discs, very limited. Most famous, again, in the knee. Why it's so complicated? Menisci, the singular is meniscus. You have medial meniscus and lateral meniscus. Together they are the menisci. And what they do is basically they're like a gasket that improves the fit and creates an additional degree of freedom. When you take a look in lab today, and you see the inferior aspect of the femur on the femoral condyles, and the tibial condyles are relatively flat. They don't look like fit. It's all about that gasket. We looked a little bit last time. We're going to start today with that because we looked at the scapula. You're going to look at that glenoid and you're going to see a labrum. And even with the acetabulum, you're going to see a labrum. That's a fibrocartilaginous slip that makes that socket a little bit more secure, much less so secure when you're dealing with the shoulder, much more so secure when you're dealing with the hip. Okay. And so and the articular discs are not limited there. What gives a lot of motion, you have one here, the sternoclavicular joint, most famously, and this is why it's a troublemaker. It's all about simplicity. When you add something inside of a joint, like the menisci in the knee, the sternoclavicular joint here, temporomandibular joint, that's something else in there that potentially could be damaged. The more things you complicate, the more things that go wrong. I mean, it's wonderful, all those wonderful toys we have on cars, or the sophisticated things we have in our computers. But if they go wrong, more difficult to fix, more problematic. So, I mean, it's just, there's a certain beauty in simplicity. So, and then you get to the bursae and tendon sheaths. Not all joints have them. Some do. The fancy term, you don't have to know this, is called fixed bursa if you have them. The knee has a bunch of those they're part of the package material. They come with the original equipment. Okay. There's some called adventitious, means they come from pressure against it. Women, when they wore, and I know that heels are not that popular today. I don't think, even for women in business, there's more flats or low heels. I mean, I don't know. My wife never wears heels. Okay. My daughter, when she wears heels, her wedding, she was like 5 inches tall. But what happens is, at my mom's day, they were dressed as heels. And what happens when you have it in a heel, it makes the ankle much less secure. So the foot begins to wobble back and forth, side to side. And that would rub against the back of a pump, a dress shoe, a dress heel. That was one routine. And they get a thing called a pumper. That was basically a kind of bursitis in the back. That was a class. Sometimes they get in the elbow, different activities, rubbing that people do, particularly occupational. It's called an olecranon bursitis. Sometimes it's something that's there, sometimes it's something that comes. So adventitious means formed because of additional friction and pressure outside of the ordinary, and it becomes inflamed. When we got heels today, we do a presentation. You go for an interview, do you wear heels or flats? Anybody? I'm just. Years ago, I did not have this. It's basically a filter. It's stop when you're going to make a bad joke, someone would offend me. So I try to limit those to as few as possible. Tendon sheaths. A tendon sheath. I'll show it to you again today. I commented on it before in the lab. Today we'll look at the humerus. When you hear about a ruptured biceps tendon, the tendon doesn't tear. It's in a sheath that's sitting in a groove in between two tubercles on your humerus. It pops out. The sheath ruptures. The tendon pops out of it. How do you fix it? Push it back in, oversew. The trouble is now for big linemen, it takes a while to heal, and the force is coming. So you're looking at basically ending a season, 8 to 12 months probably, with typical, even with today's sophisticated rehabilitation times that are there. So you see a lot of problems associated with that. So the tendon sheath is, I just remembered his name. It was one of the steel. When I get to it, it'll come to me again. So a lot of tendons, particularly going to the extremities, are sheathed. Right? So all of these tendons going to your hand or your foot, they have little tunnels they go through, and whenever they go around the turn, you have a sheath. But basically, these are buffers against friction and pressure. Okay? And this is typically where you see them when they go around turns. So here's the classic one. This is called the long head of the biceps. The biceps means two heads. It's got one head that attaches to the coracoid process on the scapula. The other head, which is what they call a super stabilizer. And what it does is it goes through that, what's called the bicipital groove or the intertubercular groove that you'll see when we look at the humerus. As it enters the joint, it is covered with this tendon sheath, which is it once in the groove, and then as it enters the joint and inserts, this is the glenoid fossa at the very top. There's a little tubercle it attaches to. So you're getting stability, and part of it, because there's very little that holds your shoulder in place, this really helps to stabilize it. The trouble is when those pass blocking with the immense power that these, it's just remarkable how these can go. Somebody to our pectoral muscle and they're gone for the season. I gotta look. So. And here, this is very famous bursa. It's called the subacromial bursa. When people get bursitis in their shoulders, this is one that's always there. This is just whenever you have muscle against muscle, tendon against muscle, muscle against bone, tendon against bone, bone against bone. When firm structures rub against each other in the interior, a lot of times we have bursal sacs that are always there, fixed, others that develop adventitious. Again, it's not a name I'm going to ask you about. We're not doing sports medicine. Additionally, 3 factors that determine the stability of joints. I don't know. You're an asshole. Okay. The most important is not muscle tone. The most important is the shape. I mean, you heard where size matters or size doesn't matter. Shape matters. The shape, whether you look at any of these joints, the shape of the joints, how well they contact each other, how they are formed, that's what determines how they move and inherently their stability. The depth of the socket is the classic example. The glenoid, golf ball on a tee, the hip socket, 2/3 of that head is surrounded, and firmly so. Okay? Ligaments, very important. Real stabilizers. And why this is, I'm not saying that muscle tone isn't important. Okay? And if you want to tell me the shoulder, the muscle tone might be the key thing, I'll buy that. The knee, I won't buy it. Arches of the foot, I won't buy it at all. To disprove that, back when I was in podiatry school, they dissected several lower extremities that they had been originally used, and they just dissected everything off, all the muscles. It would stand by itself without the foot collapsing, okay, with just bones and ligaments. So I don't know where they get this. They don't. Your cranium is in your anal orifice. Everybody get that? Your head's where the sun don't shine no more. That's all. Spaceballs, the movie. Do you remember that scene? Dark helmet. I'm surrounded by assholes. What's your name? This is Lieutenant Michael Asshole. Who's he? He's an asshole. Only from the. They're redoing the movie. I don't know what role. Mel's 99 years old. God bless him. They're redoing the movie. Rick Moranis will not do movies anymore. He didn't do the remake of Ghostbusters. He doesn't want anything else to do with it. Good for him. And this is just some selected joints you can look at. I don't do, and when we get to, I do attachments. It's the whole idea of origin and insertions. It's very much traditional anatomy. Modern functional anatomy, we look for where the muscles are attached, and at that point, we can determine what the joints do. We'll say, so all muscles attached to bone or connective tissue at no fewer than 2 points. I'll buy that. They have a start and a finish, if you want to think of it. But for years, it was the less immovable bone versus the more immovable bone. I mean, it could make sense if I'm doing a curl like that. Okay, I'm picking up something. I'm picking up a weight doing a curl. Or if I'm going to do a chin up, now that becomes the fixed point, and effectively the body and the torso becomes the object that you're moving. So that would be the origin, and that would be the insertion. They work both ways. It's like stepping on the glass or reaching up to get something in the top shelf without having to get the step ladder out. These days, my wife and I get a lot of step ladders out. And of course, our kitchen cabinetry goes up to the ceiling. Go figure. I made honey cake. You know why? Do you know what tonight is? Not that I practice. It's called Erev Rosh Hashanah. This is the start of the Jewish New Year tonight. Honey cake is a very traditional cake for that. You eat apples and honey, it's really a harvest festival and trying to bring in a sweet New Year. It's there. I'm willing to eat the holidays. I don't practice for a variety. Nevertheless, So all the different planes, and that's where you're beginning to look at them when we look specifically at the motions that are there. And I mean, now we're going to get into the specifics of the joints, how they move, and how we classify them. We'll save that for lecture on Wednesday. We'll focus on bones, the remaining bones, unless you look at them today. So, I mean, we will have to be, we're going to probably go any later than 4:30 or 4:45. Dr. Robbins has set up his practical, so he's going to have to get in there. All right. So thank you.